Before we start off, so let me start off by actually thanking you for being here. Otherwise, it would have just been the speakers and me. Um, how many of you see glaucoma patients as a routine? Just raise your hands. Okay. So a lot of us are being bombarded in meetings with little small messages saying that AI is actually going to take over the role of the glaucoma specialist very soon. And my role of today's instruction course is just to emphasize that that may happen, but we are not going to be around to see that change happening. And in the meantime, it's good to have this information going in through one ear and out through the other, and still focus on what we have been trained to do, examine a patient in the clinical perspective, because decision making is always clinical in medicine. Even if AI comes in, it will only support you. And I'll give you an example. For example, optic disc, as first described by Amli in 1969, a cup disc ratio more than 0.6 was supposed to be suggestive of a glaucoma. They even defined this statistically, saying that if you see an optic disc where the cup disc ratio is likely to be 97.5 percentile of a normal population, then the likelihood of glaucoma is very, very high. Now, this is what AI will do, this is what mathematics and researchers will do. But it doesn't mean, because there will be an odd case which will not fulfill these criteria. And when we are in practice, we are responsible to the individual patient. People who do research, who lead epidemiological studies are responsible for larger populations. And therefore, they have to base their decision making on different criteria. But we are here as clinicians, and therefore we need to focus on the individual patients. Let me give you an example. How many of you have pizzas or make pizzas at home? So do you have when you're making the pizza, do you have a problem in getting the cheese to stick to the pizza? No. So AI, some people had this problem and put this question to AI. And this man said, I'm unable to get the cheese to stick to the pizza. AI suggested, and this is documented, that you use a non-toxic glue to get the cheese to stick to the pizza. I'll give you another question, what intelligence AI has. How many rocks should a child eat per day? Can anybody answer that? How many rocks, pieces of rocks, should a child eat per day? Now, based on some data that rocks are sources of minerals, and minerals are essential for children, the AI suggested that 2 to 3 small rocks per day, and that these should be camouflaged in chocolate and ice cream so that children are forced to take it. So this is AI intelligence as of now. Things will change, but I think it's going to be some time. So I think we're more or less ready to start off. So let me just, we are a small compact group. We'll try to focus more on interaction, but we'll keep the interaction once the speakers have finished. We have tried to keep this very practical. The format remains the same, a couple of case discussions, and followed by a small talk which will give the practical aspects of that discussion. If you have any points, please bring them up once the formal talks are over. So let me just, let me start from this side because he's the president of the Glaucoma Society of India, Dr. Satyan from Coimbatore. We have Dr. Preeti Kamdar from Bombay, Dr. Ronnie George from Chennai, Dr. Mayuri from Ahmedabad. I have two colleagues here, Dr. Divya Raj Srinivasan from Gurgaon and Dr. Jyotsna Jareda from Gurgaon. And I've covered everybody. So let me get Dr. Divya to come up and do the case presentations, please.
Slides. So good morning all. So I will start with my case presentation. So I will be talking about the factors which affect the intraocular pressure. Because understanding these factors will help us help us manage and diagnose glaucoma effectively. I have no financial disclosures. So we know intraocular pressure is the pressure exerted by the aqueous humor within the eye, and the normal range lies between 10 and 21 millimeters of mercury. Remember, it's just a guideline, so what's normal for one person may not be normal for the other. And we know high intraocular pressure is a major risk factor for glaucoma. But it's not just the only one, so there are various other factors as well. So we know that intraocular pressure is basically a balance between an aqueous production and aqueous outflow. So the major primary drainage pathway is via the trabecular meshwork. So let's dive into a few cases. So we have a 40-year-old lady who came to us for a routine eye examination with the best corrected visual acuity of 6.6 and 6, and intraocular pressure was 26 and 27 millimeters of mercury. So this is the anterior segment picture, which was within normal limits, and gonioscopy showed open angles. And the fundus picture was within normal limits. So visual field also normal. So having considered this young lady who came to us only for a routine examination, accidentally her pressures were on the higher end. So would you consider treating this patient, or is there any other parameter that you would do before initiating your treatment?
So let me just stop you for a minute. How many people will not treat this patient? So I assume that the rest of you will treat? Or is this the morning breakfast lethargy? So how many people will treat? How many people will not treat? So there's still some people who have not made up their mind. Okay.
Okay, so next important parameter to be considered is the central corneal thickness. So in this patient was around 620 and 640 microns. So we know that measurement with Goldmann applanation tonometer is most accurate when the central corneal thickness is 520 microns. And remember that thin CCTs will underestimate the intraocular pressure, and thick CCTs, thick cornea, will overestimate the intraocular pressure. So various studies were conducted which said that the relationship between a measured IOP and the central corneal thickness is not linear. So all these numbers, all these correction factors are just estimates at the best. So we have another gentleman who came to us for a routine examination again, had a best corrected visual acuity of 6.6 and 6, and intraocular pressure of 26 and 27 millimeters of mercury. So anterior segment again was within normal limits, and gonioscopy showed open angles, and this is the fundus picture, which was also within normal range. So considering this gentleman who came to us for a routine, again the pressures were high. So would you treat this patient?
So how many people will treat? So I've given you the pressures, she's given you the pressures, she's given you the corneal thickness, and they match. And the pressure is high, 26 and 27. How many people will treat? Okay. The others will not treat? Come on, you have bank balances to take care of also. Okay.
So the next important thing to consider is what is the intraocular pressure in this patient? It was 26 and 27. The second important question should be, how was it measured? So in this patient, it was by non-contact tonometry. And remember, when we did a Goldmann applanation tonometer, it is around 18 and 19 millimeters of mercury in both the eyes. So always try and follow the gold standard method for measuring the intraocular pressure. Remember, when you're dealing with intraocular pressure, it's not just the numbers to be considered, but also the technique is also important. So we have a third case where she's a 45-year-old lady who's known diabetic for 10 years and on regular treatment, presented for a routine checkup, and her best corrected visual acuity was 6.6 and 6, and intraocular pressure was 26 and 27. So this is the anterior segment picture, which was normal except for the shallow chambers, and the fundus was normal. So now what next for this patient to be done?
So how many people will treat? The pressures are high, cornea adjusted pressures are high, and a Goldmann applanation tonometer has been used. What else would you want? Why don't you treat? How many people will treat? Okay, good.
Any other test to be done before starting the treatment? Yes, a gonioscopy is a must for all the glaucoma patients, and when we did the gonioscopy, even on forceful indentation, the angles did not open much. So for this patient, a young lady, known diabetic for 10 years, considering that the fact that she will undergo repeated multiple dilated fundus examination and pressures were raised, a diagnosis of PSC was made, and finally she had to undergo laser peripheral iridotomy. So the take-home message is ideal. A Goldmann applanation tonometer should be done in almost all patients, and remember that CCT adjustments are necessary. As we know that thick corneas will overestimate IOP and thinner corneas will underestimate IOP, and gonioscopy is a must in all the patients who walk into the department as it guides our treatment selection. Thank you.
Can we have our slides, please?
इधर नहीं आ रहा है. It's come. Okay. So, good morning, everyone, and I thank Dr. Sood for making me a part of this wonderful IC. High IOP as a cause for blindness has been recognized since almost 150 years. But over the years, we are able to understand the relation between IOP and glaucoma better, but not completely. We are not there as yet. So, what is the current significance? The earlier definition of glaucoma included IOP, but now glaucoma is defined as a progressive optic neuropathy with a characteristic pattern of disc damage. We don't require intraocular pressure to define glaucoma. IOP is just a risk factor and not the disease itself, as was evident in the cases which Dr. Divya showed earlier. There are many studies, many theories have been postulated. But till date, IOP remains the only modifiable risk factor in the treatment of glaucoma. We now know that glaucomatous damage occurs across the IOP spectrum. We are used to boxing patients into normal tension glaucoma, ocular hypertensive, POAG. But we now know that susceptibility of a patient's eye to IOP depends on other factors also, all right? And a patient developing glaucoma at a lower IOP may have factors which increase their susceptibility to damage. But in general, the principle is higher the IOP, higher the chances of developing glaucoma. This is a graph which even Dr. Divya showed. So earlier when population studies were done, the IOP in the population, the mean was 16. Two standard deviations about 16 was 21. And hence the magic number of 21, the earlier the association between glaucoma and IOP was an absolute. Patients with an IOP greater than 21, you have glaucoma and you need treatment. But no longer. We have now realized that, is there a pointer? Pointer here?
I didn't expect you to use the...
I'm doing that, but there is. Okay, now it's there. So we have now realized that the distribution is skewed to the right, which means there are quite a few patients in whom pressures are above 20 and they will never develop glaucoma. So that is what it is. So there is no magic number of 21. Studies still use 21 as a number, but that is for different reasons. In clinical practice, 21 is just be careful. That's what it is. So IOP lowering definitely reduces the risk of progression, and this is the crux of glaucoma management. The fact that IOP reduction is a modifiable risk factor in the pathogenesis and progression of glaucoma has been proved by different studies which had patients across the glaucoma spectrum. Normal tension glaucoma, advanced glaucoma intervention study. In every study it was proved that yes, if you lower the IOP, the progression, you are able to slow or stop progression. Our current method, to this day, standard clinical practice relies almost exclusively on in-office tonometry. This is far short of ideal, and those who are glaucoma suspects, we probably take IOP once a year. In a glaucoma treated patient, 3 to 4 times a year. And such snapshots of IOP, they miss spikes of IOP, they do not adequately measure responses to therapy, they do not capture IOP fluctuations. So that's a very flawed way, but that's most of the time, that's how we are functioning. Another thing, methods of measuring IOP are assumptions. Each method has its own pros and cons. To this day, along with all its fallacies, Goldman applanation tonometer remains the gold standard in in measuring IOP. In special conditions, you may use other methods like say tonopen or a rebound, but GAT remains the gold standard for measuring intraocular pressure. Currently, we have other methods where home tonometry with the rebound tonometer is gaining acceptance, particularly in some patients in whom there is progression even after a good control of IOP. And to conclude, what does all this mean for the clinician? It means if you see disc damage, look for IOP. IOP is the first risk factor. The ability to cause glaucoma is different for different people. Do not start treatment based on a single reading. Do not change treatment based on a single reading. IOP reduction helps even if the IOP is low. Continuous IOP monitoring in some patients will be helpful. Thank you for a very patient listening.
Good morning, all. So the next part of the discussion will be on the importance of optic disc evaluation. I have no financial disclosures. So we know optic disc evaluation is a part of comprehensive eye examination. And pertaining to glaucoma, it helps in the detection of glaucoma and monitors the progression of the condition. These are various parameters by which we evaluate an optic disc. And even any subtle change in the optic disc can be an early indicator of glaucoma. So let us see how these parameters helps us in our decision making. So going to our first case, we have a 28-year-old lady who came to us for a second opinion, presented with the best corrected visual acuity of 6.6 N6 and intraocular pressure, cornea adjusted measured by GAT at 3:30 p.m. was 23 in right eye and 19 millimeters of mercury in the left eye. Anterior segment examination was within normal limits and gonioscopy showed open angles. This is the fundus picture of both the eyes. So where we can see the disc appears slightly larger than normal, and there's a healthy neuroretinal rim and good RNFL visibility, and the CD ratio is around 0.7:1. Now considering the disc changes, so the question here is whether to treat this patient or not. And for that we should know whether the disc is normal or abnormal. So we did a visual field analysis and it came out to be normal, and even the OCT showed normal OCT picture, and it corroborated with a large disc size. So having considered the OCT to be normal and the visual field to be normal, would you treat this patient now?
So how many would treat this patient? Good.
Okay, let's have a closer picture of this disc. So if you see in the left eye, so the inferior rim is wider than the superior rim and the ISNT rule is maintained. But in the right eye, if you see, the vessel bending is here. So the inferior rim is thinner than the superior rim. So the ISNT rule is not maintained here. And when you correlate the disc picture with that of the visual field, we can see that there are superior defects in the field. But the Anderson's criteria is not met. So the alarm bell should ring whether it could be an early glaucomatous change. However, in the left eye it was normal. So will you treat now?
So how many would like to treat this patient?
Yes. Okay, coming to second case. We have a 28-year-old female who came to us with a headache, history of headache, nil significant history, with a visual acuity of 6.6 N6 and intraocular pressure cornea adjusted was 15 millimeters of mercury in both the eyes. Anterior segment again normal and gonioscopy showed open angles. So this is the fundus picture of both the eyes. In the right eye was absolutely normal, and if you see in the left eye, the disc appears large with an inferior rim loss. Okay, so when visual field analysis was done, so right eye was normal, And in the left eye, corresponding to the inferior rim loss, there's a superior hemifield defect. Now, considering only the visual field alone, will you start your treatment?
So how many will not treat? All the others will treat actually. There are just about 10% who have said they will not treat. That means about 80-90% will treat. Okay.
Okay, let's have a closer picture of this disc picture. So if you see, the disc appears large, it's irregular, but when you see here, there's a clear, demarcated, deep excavation which is seen. Absence of a neural and the retinal tissue, and it is suggestive of a coloboma, which has produced the superior hemifield defect. On a dilated examination, we picked up retinal colobomas as well. So now, considering this, would you treat or not? Okay. So we should be aware of the mimickers of glaucomatous optic disc because it can also produce visual field defects. Now going to our third case, we have a 45-year-old gentleman with a family history of glaucoma, came for a routine examination with the best corrected visual acuity of 6, 6, and 6, and pressures were 20 millimeters of mercury in both the eyes. So anterior segment with the normal limits and gonioscopy showed open angles. So this is the undilated fundus picture, which showed symmetrical cupping in both the eyes. And obviously, we did baseline glaucoma tests. And this is the visual field picture of both the eyes. OCT showed a symmetrical borderline thinning in both the eyes. This is the dilated fundus picture. Okay, so when we have a closer look at the disc, we say it's an average size disc, but the inferior rim is thinning. Thinning is seen, okay? And as compared to the superior rim, so there is a ISNT rule is not followed. At the same time, we can appreciate the RNFL defects here. So when you correlate the findings with that of the visual fields, we can see there are corresponding changes happening in the fields. So now it's a straightforward case of primary open-angle glaucoma where the treatment has to be initiated for this patient. So the take-home message will be optic disc evaluation is essential in the glaucoma diagnosis, and the dictum is here to dilate each and every patient who walks into the glaucoma clinic. Also remember that technology is just to support our clinical findings, and solely relying too much on technology can often be misleading. Thank you.
Thank you, Devan. And yeah. Yeah, the optic nerve head in glaucoma, that is the topic given to me in today's clinical scenario. So we have about 1.2 million axons, which is divided by septa, and there are about 1,000 fascicles. That's what we are going to look into deeper. So these are the contents that I'll be kind of focusing on in this 5 minutes talk. So we have multiple ways how we can do the examination of the fundus, but I prefer only these two, like slit lamp as well as the fundus photography. But I want you to really appreciate how big is going to be the fundus photography in comparison to what we see in our, even if it is dilated fundus examination. So this is what is the area of interest for us. And then many of us do draw the picture in the case sheets, but now as the EMR has come up, that most of the time we are not drawing it. So there are different disc sizes varying from less than 1.5 and, sorry, yeah, it's a little slow here, yeah. Small, medium, and the large disc. It has its own importance, let's see. And there are different shapes, especially the pierce-shaped ones is the commonly mistaken for an inferior notch, and then we diagnose it as glaucoma, and then we come up with all the treatment modalities. And then there are different, many patients will have a asymmetry, and then again we have the confusion of whether the patient has a glaucoma or it is normal. So this is the area of interest as we have discussed. Looking at the disc size, how many of us really measure the disc size? Most of us, we don't. It is just an assumption that we think that is a small disc or a moderate or large disc, but ideally if you can go with your BMO based disc margin, then we have the disc size accurately measured. You can see the small disc, the BMI area is about 1.6, that is a normal size, in comparison to the disc which is about 3.38, that is a large disc. So why is this important for us? The true disc margin has a lot of clinical relevance because this is how we see in our 90D. This is the clinical disc margin. We look at the inner edge of the scleral ring and then we say that is a disc margin. But when we do it with the OCT, the disc margin is completely different. That is what we pick up as a Brooks membrane opening, BMO opening disc margin. See the difference between these two. The green one is the clinically assessed and the red one is the OCT based. Because in the OCT based, the blood vessels and the retinal nerve fiber cannot penetrate the Brooks membrane opening. That is the main reason we say that is the true disc margin. We will discuss that when we have some time, and it is correlated very well with the functional visual field changes. So we can discuss that over when we have the discussion time. Looking at the small disc and the large disc, what is the clinical relevance? Large disc will have a larger circumference, so the nerve fiber can be spread out, the axons can be spread out. In a small disc, it is all crowded. When you really clinically look at in your OCT, see the top, that is called as a micropapillae, that is a small disc. With the crowding, it lies in the top of the line. In the green zone, it lies in the top. And when it is the macropapillae, that is a large disc, will be lying in the bottom of the green zone. So you should not take that as abnormal. If the micropapillae zone has come down in the bottom, that means again the patient still has a glaucoma. If the macropapillae has gone up, probably the patient has a disc edema. So you'll have to be a little careful on reading your OCT pictures. Looking at the RNFL layer defects, what we really see is many times we may have the confusion of whether that is true glaucomatous or non-glaucomatous defects, which may again arise from the disc margin. So let's see the glaucomatous defects. Many times we may not be able to really pick up, but once you can use the red free, then you can really pick up the glaucomatous defects, RNFL loss. See this very, very tiny defect, that is a slit defects, that arrow shows there, and then you can see the defect is becoming larger as the cup increases in size. And you can see here what is the pattern that you need to observe is look at the inferior RNFL loss, the first picture on the top. It is more closer to the papillomacular bundle. Once it is more closer to the papillomacular bundle, that is most likely a NTG pattern that we need to understand. And you see the second and third picture, it is not very close, it is little away from that. You can see that, and it is kind of progressing. We need to understand that. Then looking at the total RNFL loss, you can see as though it appears very clean, and all the blood vessels will appear to be more brighter than what it is normally seen. You can see the healthy RNFL versus the total RNFL loss, both superior and inferior. And looking at the RNFL loss, you see at the top again, there are the peripheral RNFL defects. The peripheral RNFL defects are very important again. It could indicate patient may be having multiple sclerosis, thyroid disorders, Alzheimer's, and all the B12 deficiencies, high homocysteine levels, all this you can really pick up from that. And you see the right hand side picture that typically has the glaucomatous in origin with the inferior RNFL loss. And looking at the disc hemorrhage, you see the disc hemorrhage of first picture on the left. You can see the RNFL loss superiorly. And you see the second picture, there is a same kind of a splinter hemorrhage, but there is no RNFL loss. It could be of various other reasons. And see the progression of the disc hemorrhage. Once it disappears, it leaves out a RNFL loss. Please pick up that. If you can pick up that, then that is very typical of glaucomatous in origin. And looking at this, there are two different types of optic pits. One is the congenital optic pit, another one is the acquired optic pit. The congenital optic pit, you can see that it leaves out a large area of inferior RNFL loss. Usually it is typically only in the inferior area. The congenital optic pits are mostly in the temporal side, leaving out a small area of defects also. So these are the optic pits. And looking at the RNFL loss, You might see that the RNFL loss, you can see the superior RNFL loss in a large area, and you see again one more RNFL loss here also. Both these are patients who had a stroke. It is not from the glaucomatous origin, but you see the cup, absolutely there is no cup. This is a fresh patient of about 4 weeks. It's not fresh, means 4 weeks, at least 4 to 6 weeks it takes time for the RNFL defect to be formed. And you see how it is above. It is not at the glaucoma zone. So you have to pick it up. So there are so many examples we can show. As Devan has given me only 5 minutes, I'm just showing some clinically relevant pictures for you to take home some message. Thank you.
So since the speakers are keeping to time, I think we'll have ample time for discussion, and we'll do all that towards the end of the talks.
Good morning, everyone. I'm Dr. Jyotsna Jareda, and I'll be discussing few cases for interpretation and analysis of visual field. So, no financial disclosures. My first case is a 43-year-old male who was diagnosed as glaucoma suspect somewhere else, however was not started on an AGM. He has no family history of glaucoma, no history of any systemic illness. On examination, his best corrected visual acuity was 6.6 and N6 in both eyes. Applanation tonometry adjusted for central corneal thickness was 16 millimeter of mercury in right eye, and in left eye was 14 millimeter of mercury. On slit lamp examination, both eye anterior chamber was found deep, and on gonioscopy, both angles were open. So this is the fundus photo. The right eye optic disc was slightly larger, cup disc ratio was 0.6, and there was a parapapillary atrophy present. In left eye, cup disc ratio was 0.7, parapapillary atrophy. So we made a diagnosis of glaucoma suspect both eye. So now when a patient with no family history, best corrected visual acuity 6.6, intraocular pressure 16 and 14, whether should we start treatment or not for this patient on the basis of looking at the optic disc. So we did OCT next. OCT was found to be both eye normal. We did visual fields for both eyes. In right eye, visual field was normal. In left eye, we could see that there was nasal step, nasal depression was there, and we could see that there was paracentral scotoma. So again, we magnified we saw the dilated fundus again of the left eye, and we could see that there was initial RNFL loss presenting in superior-temporal quadrant. Can you see this? So even though the OCT was normal, optic disc NRR was looking normal, but there was superior-temporal thinning was present, which was also visible on red-free photograph. So which was the defect which we could see on superior temporal quadrant. It was similar to what we could see in HVF. So now we had started the patient on treatment, even though the disc and NRR looked normal. So my second case is a 50-year-old male who presented to us in March 2025. He had a chief complaint of blurring of vision in both eyes since 6 months. He was both diabetic and hypertension, hypertension, and there was a raised systolic blood pressure was documented for him. Best corrected visual acuity in right eye was 6.9 and left eye was 6.6. His corneal thickness adjusted IOP was 16 and 17. On slit lamp examination, anterior segment was normal and anterior chambers was deep. Gonioscopy was done and both eyes angles were found to be open. So this is an undilated picture. We could see in right eye the average size disc, cup disc ratio of 0.6. NRR looked healthy. Inferior rim was larger than superior rim. In left eye, we could see that the cup disc ratio was of 0.7. Parapapillary atrophy was present. So we made a diagnosis of glaucoma suspect for both eyes. So again, the same on the basis of looking at the optic disc, should we start treatment or not for this patient? We went ahead with OCT. There were changes in right eye OCT. Left eye also showed changes. We did visual field for the patient. In right eye, we could see that there was temporal scotoma, which was respecting the vertical midline. And in left eye also, there was vertical scotoma, which was respecting the midline. So when we dilated the fundus and we saw, in left eye, there was cup disc ratio 0.6 with slight temporal pallor was visible. So a diagnosis, we could see in visual field, there was right homonymous hemianopia MRI brain was suggested to the patient, and there was found to be a hematoma present in his brain. So my third case is a 58-year-old female who had come to us for second opinion of cataract surgery. She was both diabetic and hypertensive, and there was no family history of glaucoma. Best corrected visual acuity was 612 and N18 in both eyes. Applanation tonometry adjusted for corneal thickness was 19 millimeter of mercury and 20 millimeter of mercury. On slit lamp examination, both eye had immature senile cataract of NS grade 2, and on gonioscopy, both eye angles were open. This is an undilated photo. Cup disc ratio, disc appeared to be large in right eye with cup disc ratio of 0.7, inferior rim thinning. In left eye also, cup disc ratio was large with cup disc ratio of almost 0.6. So we made a diagnosis of both eye immature senile cataract and glaucoma suspect for the patient. We did the visual field for the patient. We could see in right eye there was superior hemispheric changes were present. Left eye was more or less like a learning curve. Then we did 10-2 for the right eye since there were changes in right eye which was involving the center. So when we did 10-2, we could see that there was split fixation. OCT in right eye, there was inferior thinning. Left eye was normal. So when we dilated the patient and we saw, we could see that there was optic disc pit present in the inferotemporal quadrant. But since in visual field there were changes which was involving the center, cup disc ratio was large, we had started the patient on medication. That's it. So my take-home message is investigation in glaucoma plays a supportive rather than a primary role in diagnosis. The mainstay of diagnosis relies on a comprehensive clinical evaluation, including patient history, symptom assessment, and a thorough examination of the optic nerve head. While visual field testing and OCT provides valuable supplementary information, they are corollary to the diagnosis and are used as support clinical finding rather than establish the diagnosis on their own.
Thank you, Dr. Jyotsna.
Thank you, Raven. I'm going to share some of the points how to read the visual field out to avoid the pitfalls in the diagnosis. The single field printout comes like this and can be divided into various segments for the proper diagnosis. The uppermost part is for the patient's identity and test parameters. So verify that you are looking at the correct patient's data and the test information. Ensure you have a correct patient name put into that, and date of the birth is very important as the age is a factor in comparing the visual field results to normal. Then the test parameter confirms that specific test type and stimulus size has been used, and correct eye visual field is then. As I said, date is very important. Instead of putting the 1927 patient's date, misentered as a 1972, the visual field of the old person will be compared to the young person, and it will show you the uniform depression of the hill of vision. The strategies are very important. Usually, by default, we use the size 3 stimulus, unless it is advanced case of glaucoma, where you can use the size 5. And the visual acuity should always be mentioned, and the refractive error also. And the pupil size is also very important. Like this is the patient who was on miotic, and after stopping the miotic, we did repeat the visual field, and there was an improvement. So pupil size is also very important. Then assess the reliability of the patient's performance. So various indices are there, fixation losses or fixation monitoring. These are the two ways of doing it. Hell-Crocus blind spot method is used in Humphrey, while fixation monitoring is done in the octopus field. So approximately every 10 stimulus is projected into the blind spot area, and if it is seen, it is considered as a fixation loss. You can also use the gaze tracker video monitoring, which is at the bottom of the printout. The fixation monitoring is very good. If the cross is out of the pupil, then the machine stops on its own, and then again you center the thing and it comes. So unsteady gaze is also not a good performance. So here I have shown if there is a large eye deviation, the upward spike comes. If there are small blinks, it is an inverted small spikes. So this is a very good steady fixation. If the large eye movements are there, you have to repeat the fields and re-counsel the patient. So sometimes patient is fixating at a wrong place. So here the blind spot is located inferiorly, and here the patient is fixating at the rectangular target or at the bottom, which would be used in the patient with the macular pathology. So these are the fields which requires repetition. The false positive defect is seen with the trigger-happy patient. It gives you elevated false plus signs, and GF, glaucoma hemifield analysis will be in the form of abnormally high sensitivity. So it will be seen as a white scotoma on the grayscale, and high positive mean defect is also seen here. The false negative field defect is seen as a clover leaf pattern, because initially patient is giving the good response, and then later on the same test point patient is giving as a negative response. And usually this repeat test is done with the 9 dB higher stimulus, and still patient is giving you negative response. And mostly this is because of the poor understanding or the lack of motivation or tiredness of the patient. Foveal threshold should always be kept on and should be correlated with the visual acuity and the mean defect. Good foveal threshold and poor visual acuity means you have to repeat the refraction of that patient, or it could be mild amblyopia. If good visual acuity is there and the decreased foveal threshold is there, it suggests the early damage. The graphic scale or gray scale usually should not be used as an interpretation, but it quickly identifies the overall depression and good for the patient's explanation. Never use this alone for the interpretation. The total deviation plots comes in the numeric values as well as probable values, and PDP is difference between the patient's response and the age-matched normal population. While the pattern deviation plot is good, it exposes the overall defect in the heel of vision, exposes the localized defect. Then the global indices are there. Various indices are available. Unless you use the threshold pathology method, it is SF and CPSD is not there with the CETA test. It's a single number representation of whole visual field and overall guidelines to assess the field. The glaucoma hemifield test is a comparison of the mirror image corresponding areas in the superior and inferior hemifield, and various language form is given within normal limits, borderline, or outside normal limits. And you have to again see the patient as a whole in this. Quickly assess, Baby's curve is available with the octopus perimeter. Quickly assesses the defect characteristic and depth. Localized defect will be appearing on the left-hand side, and the uniform depression is seen as a parallel line to the normals. So analyze the visual field pattern. Specific defects, look for the characteristic pattern of associated with different condition. Glaucoma has a various defects. Optic nerve condition can be, but before you start interpreting, beware of the artifacts that is there. Determine the reliability. You might have to repeat the fields for 2 consecutive same fields and assess the evidence of damage. This is a typical lens rim artifact. Patient's head has moved back. Should be compared with the typical double arcuate scotoma here. Arcuate scotomas are narrower near the blind spot and broader near the midline. So these are typical patterns that you see with the glaucoma patients. Retinal defects are usually deeper. Absolute scotomas are there, has a sharp borders, and they do not respect the horizontal meridian like glaucoma. Now, look both the fields together. Right eye field should be on your right side and left on the left-hand side, and then do the comparison. Never read the chart in isolation. Evaluate the visual field in conjunction with the disc finding, full dilated fundus examination, or other comorbidities. Non-glaucomatous neurological fields, they are atypical visual fields corresponding to the vertical midline. They respect the midlines, starts on the temporal side first and then nasal, unlike the glaucoma fields which are seen first on the nasal side, and they respect the horizontal meridian. Ischemic lesions can have altitudinal defect or the centrocecal scotoma. And comparison of the various fields of the same patient should be done with the same strategy. Here, the mistake has been done. The full threshold is compared with the CETA standard and again full threshold. So keynotes, make sure you are looking at the trustworthy data. Will probably take 2-3 tests to achieve the appropriate baseline. Make sure it makes sense with the other clinical findings. A visual defect must be real. To be real, it must be confirmed on the repeated test. Thank you.
Thank you, ma'am.
Good morning again. So I'll be discussing few cases for the importance of shallow anterior chamber detection and significance. No financial disclosure. My first case is a 50-year-old lady who presented to us with a chief complaint of headache which increased while reading since 1 year. Her last ocular examination was done 2 years back where she was prescribed presbyopic glasses. However, she was not using it. Her intraocular pressure was 14 and 16 millimeter of mercury. There was no significant medical history. She was using lubricating eye drop on and off. There was no family history of glaucoma. Her best corrected visual acuity was 6.6 and N6. Intraocular pressure was 12 and 13 millimeter of mercury, and central corneal thickness was 510 and 530 microns. On diffuse illumination, anterior segment was found to be normal, and on von Herrick's grading, anterior chambers were found to be deep. So a patient, a middle-aged female coming with a complaint of headache, we made a where fundus was normal, slit lamp examination, anterior chambers were found to be deep. We made a diagnosis of both eye
How many people think this could be related to glaucoma in any way? None. Okay. One. Okay.
So since she was complaining of headache which increased while reading, one could be the cause because she was not using her headache, she was not using her presbyopic glasses. But we also did gonioscopy for her. So in right eye, in inferior angle was open, still scleral spur. There were few iris processes. Left eye, in right eye, superior angle was narrow, which did not open on indentation. In left eye, inferior angle was open till scleral spur, and there were few iridotrabecular contact. It was a superior angle was narrow, which did not open on indentation. However, on indentation, patchy pigmentation was seen. Can we see here? Patchy pigmentation was there. So now again a female, we then on the basis of gonioscopy, we made a diagnosis of primary angle closure. She was advised both eye laser PI. After this, when we advised her, she told us, she gave us a history that laser PI was done for her father also. So detailed history is very important, and gonioscopy should be done for all the patients. So my second case is a 42-year-old male. He basically came for second opinion of glaucoma. He was diagnosed as glaucoma at the age of 29 years, and he was put on eye drops, timolol eye drop, and tablet acetazolamide. He was taking SOS whenever there was blurring of vision. He had a family history of glaucoma. His maternal grandmother became blind because of glaucoma. Best corrected visual acuity was 612 right eye, 624 left eye. Intraocular pressure were 12 millimeter of mercury and 15 millimeter of mercury in left eye. On diffuse illumination, we can see anterior segment was normal. On slit examination, von Herrick's grading, anterior chamber was found to be deep. So when we did fundus examination, he was found to be a myopic patient. There were myopic changes in the fundus. Disc was normal. So the probable cause for reduced visual acuity is because of myopic changes which was present in macula also. So a diagnosis of both eye glaucoma with myopia was made. So the next question, whether should we allow the patient to continue the medicine or should we stop because he has a family history also. Next, we did gonioscopy for the patient. Right eye inferior angle was open. However, there was anterior bowing of iris was present in the periphery. superior angle was narrow, which did not open on indentation. I don't have the picture of left eye inferior angle. However, it was open. We can see that superior angle was narrow, which did not open on indentation. So now our diagnosis changed. Initially, it was myopia with glaucoma. Now, after doing gonioscopy, it became myopia with primary angle closure. So the patient was advised laser PI. So we know even though the antechambers are deep and normally in myope, still this patient had primary angle closure, and hence we should do gonioscopy in all patients, whether they have shallow anterior chamber or deep anterior chamber. So my take-home message is asymptomatic angle closure is common, and gonioscopy is important for all glaucoma patients and suspects. Thank you.
We'll take the questions at the end, ma'am.
So thank you, Devan, for the kind invitation to participate in this interesting session. So I've been asked to speak about whether all shallow anterior chambers need treatment. These are my financial disclosure and none relevant to this. So if you look at how we define angle closure in the clinically, it's mechanical occlusion of the filtering portion, which is the pigmented portion of the trabecular meshwork by the peripheral iris. But what do we see actually? We cannot see the pigmented trabecular meshwork on gonioscopy, and we consider that to be angle closure. And then how much should we not be able to see to be able to label it like that? If you can't see 180 degrees, you label it as angle closure. And then you further subdivide it into an angle closure suspect, where the only thing that you have is a gonioscopic narrowness. And then you have PSC, where you have either raised intraocular pressure or synechiae or patchy pigment, as doctor just showed you. Or you have angle closure glaucoma, where you have glaucomatous optic disc and visual field changes with or without synechiae or raised intraocular pressure. So that's a whole spectrum of angle closure disease that you have. So an occludable angle is essentially a primary angle closure suspect, which was 180 degrees. You cannot see the filtering portion of the trabecular meshwork. So why don't we treat everybody who is an angle closure suspect? Well, one answer for this is this. There's very little data on how many angle closure suspects actually progress to the next stage. The only data that you have from India is from the Velo Eye survey, and there are a couple of studies from Singapore, one of which Bhaskar did, and from China. So when you look at the Velo Eye survey, which looked at primary angle closure suspects untreated over 5 years, you found that 20% progressed. And 20% progressed to the next stage, which is they developed a synechiae or high IOP. Nobody developed disc or field changes. The data from Singapore and from China is even less progression. In fact, only about 7%, but that's partly because they use very stringent progression criteria. So what does this non-visibility of the pigmented trabecular meshwork mean on gonioscopy? What is its functional significance? So the thing is, it does predispose to angle closure, but if there was actual contact, you would expect the eye pressures to be high because that portion of the trabecular meshwork is not filtering. And actually, if you look at primary angle closure suspects and you compare them with primary angle closure and other people, you find that the pressures are not different. The pressure in primary angle closure suspects as a whole group is the same as it is in normal. You actually don't find any difference there. So the IOP is similar to the normal group. So what this means is a large proportion of people will appear to have apposition on gonioscopy. That does not mean that there is pathological damage which is causing a problem. So non-visibility of the pigmented trabecular meshwork on gonioscopy is not necessarily a clinical issue. The other reason why you don't treat everybody is that's a map of Canada. And I put it there because as many people live in Canada are primary angle closure suspects in India. Approximately 30 million people. You can't go around doing 30 million YAG-PIs for a disease which does not really have a very high progression rate. And that's the reason why we are not so fussy about treating all angle closure suspects. The other risk is if you actually do a laser iridotomy for everybody, we have data from the Chennai glaucoma study which shows that it increases the risk of cataract formation marginally. So if you decide to go and do YAG-PI for 30 million people out there, all cataract surgeons will be happy a few years down the line because many of those patients will progress. So what are the indications? Well, obviously, if you have an acute attack, you have to do it in the fellow eye as well as this eye. If you have a family history of glaucoma, definitely it's a strong indication for a YAG peripheral iridotomy. If you have somebody who requires frequent pupillary dilatations or coming from a very remote place, doesn't have access to care, or one-eyed patients, definitely go ahead and do the YAG PI. If you have a patient who's very concerned, there's no harm done in doing a YAG PI. If you have a patient who's very difficult to indent open, again, that's one more indication for doing a YAG PI. So when you look at a laser iridotomy for PACS, not everyone needs it, but everybody who has it needs follow-up and monitoring and explanation that this is an issue that they have. It's better to give that in writing because that tells you that you've informed them of the risk and that they need to be followed up. Thank you.
I'd like to thank the speakers for sticking to time. Please don't go away because the actual discussion starts now. And Ronnie, I just have a quick word. It would be politically incorrect to compare Canada with India, actually, till about a month back. So I think you need to be a little careful.
I'll put Australia next time.
Yeah. So I think if you see the speakers, they have, with examples, nicely woven take-home messages. And I'm going to come back, re-emphasize some of those. For example, there is a sequence of approaching the glaucoma patient. Very often in busy clinics, the patient's already seated when we come into the room. But ideally, we should be able to converse with a little time because the key to good glaucoma management is diagnosis. The primary glaucomas, you will be able to diagnose by your examination. But the secondary glaucomas, you need to talk to the patient. So it's a good idea that you converse a little bit. And if you saw one of the histories about laser PI where I said that that lady just had headaches and she came in, she denied a history of glaucoma in the family. Had that been there, the gonioscopy would have been done readily by many of us. But most of us would not do a gonioscopy for a patient who just came in as a routine headache. So the message here would be that history taking needs to be done at several levels. Patients will initially deny it. For example, if your optometrist is working up, can document no family history of glaucoma, and you could, while examining the patient, just make a statement, oh, there's no glaucoma in your family, so, and you could move on. But that repetition will actually help. The same thing applies when it comes to systemic disease. For example, asthma. Many of them will deny having asthma, though they are on treatment. And years down the line, they'll say, oh, yes, I've been on treatment for glaucoma for so many years. And then you go back and look at your notes, and that was something you took for granted. One question, and let's start with the intraocular pressure part. I'm very glad nobody's talked about the Schiot's tonometer after a very long time over here. Now, the focus for instrument of choice for everyone is a Goldman applanation tonometer, and two speakers showed that the normal range of pressure was 11 to 21. Now, here's my question. Now, 11 to 21 was described by Leydecke using the Schiot's tonometer. Why are you interpolating that data to Goldman applanation tonometry? So I'll, instead of asking everyone, I'll just put snapshot questions. We also have Dr. Mani Bhaskaran, who's done the Singapore study. So Ronnie, this question is to you. Why do we interpolate this data?
Yeah, so essentially, even though the data came from Schiot's tonometry, the information for normative data from our population comes from population-based studies, where we have examined a large number of normal people who have had normal normal fields. You look at what the intraocular pressure is in those eyes, and you take the mean plus or minus 2 standard deviations. And from the Chennai glaucoma study, which examined about 7,800 patients, we know that that normal range is approximately 10 to 21. It's a little higher in urban population where it's about 22, but that's a range. So most population-based studies, except for the ones in Japan, have, even with applanation tonometry, have come to the same range now.
So it would be fair to say that what Leydecke found with his Schiot's tonometer, we can apply the same criteria with Goldman applanation tonometry.
Yes, with just one caveat, that the lower level doesn't really matter.
The lower level. So again, the lower level matters because I can't diagnose normotension glaucoma and go in for fancy investigations if that concept is not there.
That's only the upper level, the lower.
Corneal thickness. How often would you measure corneal thickness? That's the first question. Dr. Mayuri, if you can just take this question.
When I see the patient for the first time of glaucoma, I always ask for the corneal thickness before I start examining the patient.
Okay, so
When I suspect the glaucoma.
So first interaction with the patient, mandatory to get a corneal thickness done. Dr. Preeti, is that the same?
Yes, for all glaucoma patients, yes, several corneal thickness. But however, one thing is there is no conversion normal.
So I'm coming to that. I'm coming to that. So one thing is, are Indian corneas thinner than the average corneas that the Goldman applanation tonometer was described for? I say this because there was a newspaper report which said Indian eyes are thinner and not suited for LASIK.
Yeah, that wasn't from us, but
It
if you
was
look,
from here.
yeah,
Delhi.
but if you actually look at Indian corneas, the average thickness of at least the South Indian urban cornea is about 520 microns, but a South Indian rural cornea is about 500 microns. So we are a little thinner than what has been reported in a Western population, but this 20 microns probably doesn't make a huge difference. And Western corneas are the average thickness in most studies is actually closer to 550, not even 520. So 520 is more or less close to Goldman territory. 500 is a little bit on the lower side, but it's not a huge issue.
We also had something 515 was our average.
Yes.
So I understand that the Goldman applanation tonometer was made for Indian eyes.
Yes, absolutely.
So now here's the question. You have a cornea which is 600 microns. You have a cornea which is 500 microns, two different patients. Are you going to make some adjustments in your IOP measurement for these patients?
No.
No. Anybody else who will?
Basically, actually, the corneal thickness values are more important for those with the suspects than with the established glaucomas.
Okay.
So we use more of this to say sometimes we have a confusion of to treat or not to treat. The corneal thickness, if it is higher, the possibility of progression to the next stage may be a possibility. But when it is really too thin, the chances may be a little higher than those with the higher thickness values.
So
But
this
in
is like-
established glaucomas, corneal thickness values doesn't matter. Maybe it helps us in sometimes, maybe these patients may have a slightly higher chance, maybe a higher chance of progression. But
So-
otherwise,
Corneal thickness as a bearing to say to treat or not to treat.
it is not to treat, it is just when you have a cat on the wall, this may be just an additional tool for you to treat or not to treat.
Or like what William Shakespeare said, to be or not to be. Okay. So here's the next question. What normogram would you use?
I just keep in mind that, okay, this cornea is thicker and the chances that this person will have a higher IOP, artifactually higher IOP are more. But even then, having said that, I will still follow up because there were patients in the OAT study where they found the cornea is thick, they did not treat, and even after adjusting whatever mentally, some of them still progressed.
We want to know how did they adjust? What did they adjust?
There was no normogram.
So any
was no
normogram which the
normogram.
how panelists suggest that we can use as a take-home message? I agree with her that there is no accepted normogram.
Normogram, yes.
But then what? Everybody in every meeting says the cornea is thicker, so you have to make an adjustment. But I'm asking on behalf of all of them, what should I adjust with?
Don't adjust with anything. Mentally have a number, but generally, I mean, this is just rule of thumb. That doesn't mean that you do a calculation on paper. Approximately 20 microns, 1 millimeters. But it's not. It is just a very, very rough rule of thumb, and I really would not. Please don't write it down.
No, because there are some softwares which patients use in their clinic and automatically a corrected
Convert.
IOP is given.
Is that acceptable?
No.
So every machine is very happy to give you a corrected IOP, but none of them agree with each other.
Can I?
Yes, please, Mani.
Quick thing is, what I do is when you have a thinner CCT and an established glaucoma patient, I'll treat them aggressively. Make it little more towards the lower teens if that is advanced and moderate glaucomas, because usually we underestimate the IOP and undertreat. So that is the only thing I would think about. Higher CCTs, I may be follow-ups, I may be a little more lax, but still I would be vigilant about. It is more like the pickle in your food. Pickle is essential, but you won't just take the pickle alone, no? So you have to look at everything. The patient's whole investigation should be done.
So you can't make a whole meal out of pickle. So the other thing is corneal thickness is important not just for diagnosis, but also in those patients who are progressing despite the intraocular pressure being in the desirable range. So they may be having thinner corneas, and here would be the issue, the measured IOP is higher than the actual IOP in patients who are progressing. So that's how it would all boil down to be. I think let's just move on. One last question. Would you measure central corneal thickness or peripheral corneal thickness?
Central.
Central cornea. And any preferred instrument of choice, whether it should be ultrasound based or whether it should be an optical pachymeter, would that make a difference to my measurements?
So what happens is when you use an optical pachymeter, most of them include the tear film in the thickness measurements. So your thickness measurements with an optical are usually slightly higher versus a contact.
Yeah, but at the same time, we don't know whether we are measuring the central corneal thickness in ultrasound pachymetry also. Because there's a huge variance when we did that. Only when you do the optical, by the visual axis, when we measure, the measurements are only about 1 to 2 micron variance. But when we measured with the ultrasound, the variance goes up to even 20 microns. It depends upon the staff, the tilt angle, where the patient is fixing. It is a huge variance in the ultrasound packing.
Having said that, we actually repeated pachymetry measurements at 5-year intervals in about 4,000 of our glaucoma, of our study patients, and the typical variance was, I think, under 6 microns.
So if you keep in mind that when you look at a concept like precision for IOP measurement, and you say the intra-observer variability for Goldman applanation tonometer is about 2.5 millimeters of mercury, isn't that going to take care of small fluctuations or changes in corneal thickness like that?
Absolutely. So even if you look at repeat testing, the variation is not high. It's not really enough to impact your interpretation and of its impact on IOP.
So go back and look at the current definition of glaucoma. It does not use the word intraocular pressure. You don't need to have high intraocular pressures. And still you measure intraocular pressure because you're using it as a surrogate marker to assess the response to treatment. So keep that in mind. Let's move on. Optic disc evaluation. Mandatory for all patients at the first visit?
Absolutely.
Absolutely. And instrument of choice. So how many of you would see the patient at the first visit, undilated, you've seen with the 98D? Would you prefer a 98 or a 78 or a 60 diopter lens as a first choice?
Whichever you are used to. I'm used to 90D.
Yeah, so I want to hear what you
Yes.
are using.
I'm using 90D.
Anybody else who's differing from the 90D lens?
90 is fine, but 78 may be a little better for glaucoma.
Okay, but undilated 90 would be better.
Yeah,
78 would work very well with a dilated pupil. So one thing is, every time you see an optic disc, and here's my suggestion, and you can comment, when you see a disc and you're thinking in terms of glaucoma, seeing the disc, you should be able to say what kind of visual field changes you would expect if this is a glaucoma disc. The same thing will apply when you see a visual field in isolation. When you see a visual fields, you should mentally be able to picturize what kind of an optic disc change you would expect if you're thinking in terms of glaucoma. Now, this becomes very important because when you see an optic disc, you should be able to say, does it match with the visual field changes? And if you see a visual field and then see the optic disc, you say, my visual fields corroborate or correlate with my optic disc changes. Again, the other aspect is that why do we do visual fields? Because visual fields are no longer in the definition for glaucoma. So are we making our patients waste money by doing visual fields? Preeti?
Actually, even intraocular pressure is not in the definition of glaucoma.
But still we measure.
Yeah, exactly. So glaucoma is a disease where IOP, perimetry is not in the definition, but we are treating patients and monitoring patients based on IOP and perimetry. Perimetry remains the only functional test, and we are interested in function. My little finger might be crooked, but if it's able to hold weight, I'm able to write properly, that's what I want to do. So that's how it is. So perimetry remains the functional test, and I don't think it's going away ever.
But they've removed it from the definition. Actually.
Absolutely.
It's
It
in
is
the
not in
process
the
of going away.
definition. So that's pre-perimetric glaucoma. So disc evaluation, the disc is the story of glaucoma, but however, perimetry and intraocular pressure are so important.
How many of you find this concept very confusing? Perimetric glaucoma, pre-perimetric glaucoma, structural change? Yes or no? So let's do away with the perimeter. There's no pre-perimetric glaucoma. There's always glaucoma. There's always a nice red color on the OCT printout, and you can start treatment with. No. I'm coming to emphasize that. But, again, we showed you examples where the fields were showing a change, but actually there was no glaucoma. The reverse will also hold true. Your OCT will show a change because in a very simplistic manner, normal has to be predefined statistically for the OCT to function. So if, say, the optic disc size has been described as X, and you see an optic disc larger than that, all measurements are going to change on the OCT. And therefore, when they do the statistical comparison, there's going to be a mismatch and you're going to have red color. That's another simple example. The average height is say 4 to 6 feet. But if you see a 6.5 feet person, his arm spans or all body parameters are going to be different. And therefore, he will appear to be abnormal while actually he can be normal. So keep this example in mind. Similarly, the same will apply to a person whose height is less than what you would expect for normal. Just because height is the criteria, he may appear to be, but that doesn't make him abnormal. How do you respond when a patient comes to you having got an OCT on, say, X machine, and now he has gone and shown a second place and on a X to a different brand of machine, and he's come to you now asking, I was diagnosed to have progression over there. How do you tackle this patient?
Is that progression or glaucoma?
The
Okay.
OCT, the progression has been defined by the second OCT, which was done on a different brand machine.
Yeah, so you just can't. You cannot compare two machines. What they measure is different. A thickness here is not equivalent to a thickness on another machine. And even on the same machine, unless you have registered the first measurement, the second measurement is not comparable to the first measurement. Unless you have overlapped the exact circle of measurement.
So is there a consensus on this?
Even if it is the same machine, same place, just with the OCT alone, I'm not going to say it is progression.
Why? They're doing so many studies and spending money and having so many meetings where they say progression is based on OCT and...
Unless it is corroborated with your functional change, and whether it is going to be useful progression that is to be stopped by for that particular
But
patient.
doctor, you're investing money and buying such an expensive equipment to assess progression, and if you're buying and using this for your patient repeatedly and not actually using, just imagine how heartbroken the patient would
Not
be.
actually using, I know where you're coming to, but I would like to give the proper thing to the audience. Basically,
Achha, tell me, am I
you
wrong
need
in putting this question? So they're supporting me actually.
as long as we are having a functional change registered or a difference in the two corroborated with other findings, you need to, because it's a syndromic thing. You can't just depend on just one investigation and make a treatment there.
So here's, I'm willing to do more investigations as long as the patient is paying. So here's my question. Okay, we'll come to that part again. But again, you know, the question is very interesting. For many of us, we use the word progression very casually in our clinics. I've said this earlier also. From a patient's perspective, progression is disastrous when the doctor uses this word. He thinks, I've been coming to this doctor repeatedly for so many visits or years, and now he's talking about progression. He has actually not treated me well, and my disease is progressing. I need to sue him. This is a thought which runs through our mind. So when we come to meetings and we talk about progressions and the way we put it across, if we put it the same way across, patients are going to get dissatisfied with what we are doing. So this is something that we need to keep in mind. So there was a question coming from the lady in the back. Would you please speak loudly and tell us?
It was regarding the case studies for routine when a 50-year-old lady presented for presbyopia correction. What was the indication of doing gonioscopy in that patient? And plus, what is the treatment protocol or rather course of action post YAG PI?
Well, that's a very interesting question. Let me rephrase this. Can angle closure, is the presentation, what is the classical presentation for angle closure? Bhaskar, let's put this to you because in Singapore you have had a snapshot of different populations. How would angle closure present typically? Not the textbook, headache, colored circles on bright light. Not acute angle closure. So a typical angle closure, can you just listen to the patient's symptoms and say this is angle closure? No. Anybody from the panel, other panelists?
The huge majority is asymptomatic.
Sometimes they can complain of frequent headaches, off and on, changes of the presbyopic correction.
Changes in press
Frequent
back. So
changes.
headache is not uncommon. In fact, there's a study from RP Center where they have looked at the classical presentation of angle closure as described in the textbook with what they have been seeing in their clinics. And they said the classical features are usually absent and angle closure mimics open angle glaucoma unless and until you look for the shallow chamber or you're doing a gonioscopy. Dr. Murli, you wanted to add something?
Yeah, I just wanted to, while the discussion is on angle closure, and we all use technology for besides gonioscopy. So you probably discuss the role of the new gadgets in screening for angle closure. I think it's a huge problem, at least I face, and all patients coming to us with different images from different machines, saying angle is 12 degrees, angle is 18 degrees, angle is 34 degrees, and so on. So the role of AIOS-OCT and these devices, while you're talking about expensive OCTs, I think you talk about OCT for the angle as well, whether it's relevant in our practice, whether gonioscopy still remains the gold standard.
So the problem with gonioscopy is that it's not expensive, and therefore we find it very difficult to realize its value and communicate this to our patients. But had this cost 30 lakhs, we would have been very aggressive in doing gonioscopy and getting the maximum out for our patients. But we are not wanting to gonioscopy and go on to fancy gadgets like anterior segment OCT and UBM because they're more expensive. And when you do something with an expensive instruments, patients are actually more satisfied. But let's hear it from them also.
I think it's got absolutely no role in screening or diagnosing.
Gonioscopy or anterior segment OCT?
Anterior segment
Segment
OCT.
imaging.
That's very interesting actually, because in your clinics you do more cataracts, you want to buy more equipment, and one of the first things you think of is an anterior segment OCT as a substitute for your gonioscope.
So we have
has one gonioscopy equipment separately. Regular gonio,
How much does it cost?
around 20 plus.
What?
Regular gonio.
So he speaks only in lakhs.
See, now you will value this gonioscope much more. So I'll come back. How often should gonioscopy be done for a patient who's been following up with you regularly? At diagnosis, we are all aware about it. Dr. Murli, you have a talk. Can you please come and load? Yeah, okay. So, Ronnie?
So our protocol is definitely at first visit, and then after that annually, or if you see any change, if you see a pressure that is going up, if you see progression that's happening and you can't explain it, always better to do a gonioscopy, because sometimes that's all that's happening. An angle that you've been treating as open can close with age.
Okay. So another aspect that comes out, and this would apply both to the tonometry and gonioscope, how do you disinfect gonioscopes and tonometers? What's the practice in your clinic?
I'm using applanation tonometry.
So how do you disinfect?
Oh, clean. I use alcohol swabs.
The regular alcohol or
The swabs are available.
the alcohol?
Alcohol
So
swabs
75%
are available.
isopropyl alcohol.
80% alcohol.
Ronnie, same thing?
Glutariate wipes.
Glutaraldehyde, these are available?
No, we use a spray. We
Okay. So spray is commercially available? I was not aware about it.
you can
You
put
can-
in a bottle. That's all.
Anybody else doing something different?
So what we do at the beginning of the session, with the first patient of the session, before that we disinfect with this disinfection with the alcohol wipe which she mentioned. And subsequently, between patients, we don't use an alcohol wipe for every patient. We use a disinfectant wipe with a sterile wipe. Just wipe it mechanically clean, and then follow up with every patient. And only once in the morning, in the beginning of the day, we start with that. And suppose we know a known infected patient or a known patient with an infection, then we again use a disinfectant. Otherwise, we don't use alcohol for every patient. But sometimes the alcohol gets left behind. We sometimes contact the cornea with the alcohol. So that's a worry. And we have no issues with just the disinfectant sterile wipe.
How many of you use water wash? Tap water.
So actually, none of you should be hesitant in saying yes, because that's the best way of doing it.
I use it.
Yeah, that's the best way of doing it. The key is to have a mechanical wipe, because fruitful Jacob disease, some protein elements get deposited on the
mechanical
tip.
wipe is the key.
Is the key actually. So a good wash under running water, simple soap, and drying is very important. The key is drying. If you can't do anything, dry. If you can do something more, running water. And fancy clinic?
That is what I am really surprised. Nobody is saying that they are not
Wiping
using
it
water.
Yeah, so I think, the mindsets have become such that we are wanting to move more technology based, and therefore things are getting left out. So any other questions from the house? Yes, ma'am, please.
So next course of action post YAG PI in the first
So,
patient.
okay, so let me just rephrase this. You've done the laser PI today. When will you see this patient next? So, okay, here's something which is very important. your follow-up criteria will depend on the kind of practice you are in. Are you an individual or are you in an institutional-based practice? So let me just categorize here and put Dr. Ronnie and Dr. Satyan and Dr. Preeti as three components because they're in different roles. Dr. Preeti is in a more individual-based practice. Satyan comes from a group practice and institution-based, and Dr. Ronnie also comes from an institution-based. Dr. Mayuri has just transitioned from an institution-based to a semi-individual-based. So just give me quickly what criteria you would follow, how frequently you would see this patient.
So I haven't changed what I was doing it at Arvind. So do the laser, because what we are talking about is a PACS I'm talking about, okay? Do the laser and immediately we see them, and then I do follow up only at the end of 10th day. When the tapering is done, everything is done, I see them on the 10th day.
Okay. Dr. Divya?
That is the first.
That's the first. Okay, PA. So Dr. Divya, what would be your criteria for follow-up?
After a laser PI, I would like to follow my patient after a week and also do a gonioscopy to see if it is open or not.
So when we say we'll follow up, it's very easy for us to say follow up. What exactly will you do when they come back for the follow-up, other than the routine vision and intraocular picture?
Yeah, a gonioscopy would be done.
So gonioscopy at the first visit, 1 week. Is there a consensus on that amongst everybody? Anybody differing from this?
No, I would definitely do the gonioscopy at the next visit. I would usually call them maybe 2 to 3 weeks because sometimes by that time, whatever pigment dispersion related or steroid related issues have settled down. But a gonioscopy is mandatory at the next visit and a dilated fundus exam if you haven't done it yet.
And in angle closure after dilation also check the eye. Sometimes even after the PI, the angles can close and the pressure can go high after, despite the pain. Okay? So those patients have to be followed up more closely. That's why. So dilated IOP is also what.
So here's my question. What is the aim of the laser iridotomy? Is it to lower the intraocular pressure? Is it to make sure that the angle opens up? Or is it to make sure that the angle doesn't close any further?
It's the pupillary block mechanism. We are addressing the pupillary block mechanism, not to lower the intraocular pressure.
Sorry, I didn't.
Pupillary block mechanism.
Pupillary block mechanism. But is it going to... So many people say, I got the laser done, my pressure has not come down. Has the procedure failed?
It depends on how much is your angle closure preferred and the plateau iris.
So here's the other part of the question. Why do we do a gonioscopy post-laser? Anyone? Why do we do gonioscopy post-laser?
So not all angles are going to open up post-laser iridotomy. Data from India suggests that about 75% of angles will open. 25% will continue to have some degree of apposition closure. Most of them are going to be plateau iris, and they require much closer follow-up, and they are more likely to progress than an angle which is completely open.
So angle closure is not just about a pupillary block to relieve the laser iridotomy. The non-pupillary mechanisms can be identified only after the laser has been done. Now, as a consensus, we have discussed how you will make the glaucoma diagnosis, and we now need to talk about treatment. Our next speaker is actually, this is a, this is actually a guest talk on patient-centered glaucoma management, the case for preservative-free medication, and our speaker is Dr. Murali Ariga. Dr. Murali.
Thank you, Dr. Devin. I think while we're treating glaucoma patients, I think the dilemma now is about should we prescribe preservative-free medication for all, and what is the choice of preservative, and what are the choices available to us, and so on. Have the slides on, please. How many of you believe that preservative-free medication is for all? For all patients across?
They're buying from my pharmacy.
Yeah, and they're all generic. So, true. There is a case for it. That's what I'm going to talk about. I think I've given my slides. It's on the laptop there.
So while he comes on with the slide, what will
The other one?
dictate your choice of medicine? Efficacy, or whether it is with a preservative or without a preservative? Efficacy.
talk is a little different.
Yes.
Yeah. So patient-centered glaucoma management and the case for preservative-free. So when we manage a glaucoma patient, we have to, of course, decide first the target intraocular pressure. We need to educate the patient regarding the disease itself, what is the nature of the disease, the need for follow-up and management and so on, and the application of eye drops. Most of us would probably demonstrate for the first time the application of an eye drop and probably teach them the punctal occlusion so that we don't get the side effects or the systemic side effects. Evaluate for systemic disease like you were talking about, asthma and health problems which can probably interact with the drug intolerance. Keep that in mind always that a patient is being prescribed a medication which he probably needs to use for the long term. And of course, we also have to keep in mind the talk which I'm going to focus on today is about the ocular surface, which is relatively common in glaucoma patients. So the adherence and support aspects for the patient that we really need to monitor whether the patients are following what has been told to them regarding the number of bottles, the number of times they have to use, and they come back for the regular follow-up and so on. Encourage lifestyle modifications which would assist them in better health and better management of their disease. Counseling of the patient and the family regarding the disease, the need for drops and the follow-up. And the most important thing is about the family screening. Once you diagnose somebody with glaucoma, don't miss the opportunity to screen the relatives, screen the siblings in particular. Don't miss the opportunity to screen for glaucoma. This is probably the best screening tool for glaucoma. Don't go into the population screening for doing glaucoma camps. It doesn't work. This is the best way to screen for glaucoma. A common reason for discontinuing glaucoma therapy is usually the ocular surface OSD, ocular surface disease development. In the general population, it's said to be somewhere between 5 to 30%, but in the glaucoma population, the people with glaucoma, the elderly with the need for drops and so on, it's much, much higher. So more the number of medications, more the number of bottles, more the number of drops per day, and the chronic duration of therapy, obviously we're going to increase the problem of ocular surface. And majority of the ocular surface, the local side effects in glaucoma therapy seems to result from the preservatives than the actual active compound itself, but there's some belief that the actual compound itself may be important in side effects, but the preservatives seem to be causing more of the local side effects, such as ocular surface inflammation, the conjunctival inflammation, allergic reactions, and of course the dry eye. We have various preservatives which are available in glaucoma medication. BAC is the one that is about 70% of our glaucoma medication has BAC, ranges from 0.003% to 0.02%, various strengths, various drugs, various companies, and it's basically a detergent. A detergent dissolves the cell membranes. We have polycard, we have SOC, we have perborate, and we have borate, sorbitol. All of them cause oxidative. Basically, what these preservatives do is they try to destroy the microbial organisms that may contaminate the bottle, and that's the reason why you're putting in a preservative. Literally like you have a preservative in your pickle, preservative in your jam. Those kind of preservatives are put into your eye drop bottle to preserve the drop and not to actually protect the patient. So, but that's a side effect of what we need to keep in mind. The cytotoxic effect of the BAC, which is the most common benzalkonium chloride, which is the most common preservative used, is decreased corneal, conjunctival, trabecular meshwork, and ciliary epithelial survival. And we all know about the conjunctiva, the cornea, and the goblet cells and so on. What we don't know, is at least many of us don't know, or till recently I didn't know, that the trabecular meshwork is also affected by the BAC. So BAC can actually influence the way the outflow actually changes and is influence the control of intraocular pressure as well. Besides all of these cytotoxic effects of BAC on ocular tissues. Does BAC worsen the glaucoma? Yes, it probably does. And the BAC exposed human trabecular meshwork as compared to trabecular meshwork of open-angle glaucoma patients, you see the studies which have been performed, the changes induced by BAC on the trabecular meshwork has been clearly demonstrated. So what does BAC do? I think in terms of symptoms, pain, discomfort, tearing, people are quite symptomatic with ocular surface staining, increased breakup time, the low Schirmer scores, the punctate keratitis, the worse OSD, so people who do the OSD evaluation, and of course the subconjunctival inflammation trial. All of us who treat glaucoma patients who have been on medication for long periods of time, you all know the eyelids can't be spread apart, the orbits tend to sink, and they have this periorbitopathy related to the prostaglandins. We have all kinds of problems, and you will find these are the candidates who don't really do well with trabeculectomy also, even though if you use antimetabolite and so on. So the clinical consequences of the BAC toxicity is that the OSD is going to be there. It's going to get worse. You've already had a pre-existing mild dry eye and so on. And also you will find the glaucoma gets worse for various reasons. One, the patient is not going to be adherent, is intolerant to drops, does not like the drops, does not tolerate the drops well, you will find the compliance adherence issues will come. The IOP control goes away, and they don't use the drops which are uncomfortable. You'll find if you give 2 bottles or 3 bottles, the most comfortable bottle will be used by the patient, and sometimes it is a lubricant. So which is why I take care not to prescribe a lubricant to all glaucoma patients as a routine, because what is most comfortable, they will use. What's uncomfortable, they will not use. So unless it's really important, don't co-prescribe a lubricant to all patients. And the long-term use of preserved medications increases the risk of surgical failure. I think we all know that this is from various publications, that people who have been on chronic therapy, especially back-containing medication, the success of trabeculectomy drops. You will not get the same result with the trabeculectomy as compared to somebody you are operating. Just maybe you diagnosed last week and you're operating this week, you will find the primary glaucoma is the results are much better with trabeculectomy than somebody who's been using back-containing medication for a long number of years. So the benefits of PF glaucoma therapy are there, definitely there. Prevents ocular surface inflammation, eliminates the side effects of the preservatives, reduces the, increases the adherence and persistence with therapy, probably maybe a little more cost effective due to the better adherence and so on. And the patient comfort is the most important thing. When you give a drop or a medication, the patient should be comfortable with that, and therefore the quality of life improves, and overall the outcome of glaucoma management improves. So many studies have compared the benefits of switching to a preservative-free glaucoma medication. The conjunctival signs and symptoms obviously get better if you use a preservative-free drop. I'm not going to go into all of the details of these publications, but it suffices for us to know that a PF medication definitely changes the scenario of signs and symptoms. Patients are a lot more comfortable. And switching actually causes a reduction in the ocular symptoms. Suppose somebody had intolerance to PF-containing medication, preservative-containing medication, you switch them to a PF, then you find that they definitely feel better. Definitely the T-bud times and their ocular surface evaluations, the scores improve with the preservative-free medication. But there's no difference. There's a little worry about the back actually helping the drug penetrate the eye. And that's why we feel that sometimes, for example, Bimidaprast, one company brought out to the Bimidaprast strength, which is actually higher back than the previous backs. So what happened was the theory was that it helps penetrate the drug penetration is assisted with the back and so on. But many trials have shown that between the PF and the non-PF containing medication, the IOP reduction is not really significant. So you can probably give a PF medication. You look at the glaucoma guidelines from various societies and publications have suggested the use of preservative-free. You avoid preservatives in people who don't tolerate these kind of drops with the preservative. And on long-term treatment with glaucoma medication, I think it's probably better, like you all suggest in the beginning. Given a choice, you would probably, it's like saying, would you like organic food or not? All of you would like the best available food if possible, given the choice, but availability, cost, and other issues prevent us from giving it in all our patients. Various technologies are available in India as well. About the one type of technology, the bottle which is available is called the Aptar bottle, which is actually made by companies like Cipla and so on. We also have the Novalia type of bottle. There's a slight difference in the bottle technology between the two. The Aptar bottle actually allows there's a sealing membrane, there's a dual channel for the drop to come in, and there's a little bit of air that gets in back into the bottle. There's a membrane which doesn't allow the air to get contaminated and go back into the bottle. That's what the Aptar is all about. Whereas the Novalia actually has some, for microbial integrity, there's some kind of a silver in the plastic material which is lined within the bottle. So that's the basic difference between the Novalia and the Aptar. Patients sometimes have a little difficulty in squeezing the bottle with both the Aptar and the Novalia because it doesn't have the nozzle appearance. It has a little bump in the bottle, as you can see. So there's a little difficulty. Patients sometimes express difficulty in getting drops out of this bottle. The drop actually appears very small. So most of us would be aware that the drop size of what we would want in a glaucoma medication should be between, let us say, 20, at the most 30, but most of the commonly available drops which we now get in our commercial glaucoma medication will give you something between 30 and 50 microliters and more. So conjunctival cul-de-sac obviously cannot hold such a large drop. So having a smaller drop actually makes a lot of sense. This is the Aptar bottle, and this is the mechanism of how the bottle actually gets the drop out. Bottle squeezing opens the tip seal, dispenses the drop, the tip seal closes and prevents the backflow. And the incoming air which goes back into the bottle actually gets filtered. So this is a very nice technology. It's very nice on at least the engineering part of it. For those of you who want to know more about the Aptar technology, the Aptar Pharma has a website which you can look up and see how the Aptar, I'm not going to show you the video of how the bottle is going to show you maybe a very brief clip of how the bottle works. I mean how the bottle sort of There's a company which makes this bottle, and you see the drop that comes out from the two channels, and as it comes out and delivers the drop, sometimes these drop technologies take ages to understand. It's a very small drop that comes out. I think it's about 15 to 20 microns. So PF therapy will definitely benefit all, but obviously we can't give this expensive, relatively more expensive, totally preservative-free glaucoma medication for all. So a targeted assessment would actually help identify those who need it the most. So you need to look at the patient history, their symptoms, the other ocular disorders, what other medication they are probably using, ask about the dry eye symptoms, the occupation, the systemic disease, systemic therapies which can actually have an effect on the possible dry eye development and so on, especially older age, the female gender, and all these history about the systemic disease. Then a quick visual assessment about the ocular surface, about the periocular skin, the debris at the canthi, the hyperemia, all of this should be evaluated, including the tear meniscus, tear film, maybe even a T-butt and a Schirmer if possible. And how much more to add to a glaucoma armamentarium? We start doing visual fields, you do gonioscopy, you do intraocular pressure, and you look at the optic disc, you take a picture, do an OCT, and finally say I want to look at the dryness as well. And then one more test and one more evaluation. So I think we need to balance the need for which test for which patient, especially the ocular surface. The symptoms, history, and a quick evaluation should actually suffice. If you really want to go further, you can actually go evaluate further and have a cornea colleague look at the ocular surface. So patients who would actually benefit the most from preservative-free glaucoma therapy are those with concomitant dry eye, patients receiving multiple bottles, very elderly patients, especially whom you know that the ocular surface is compromised, very young patients in whom you want to probably give medication for a longer duration of their lifetime, patients with serious medical risk factors, known systemic illness like rheumatoid arthritis and diseases which are known to cause dry eye. You're going to plan for a glaucoma surgery in which you want to stop the medication containing back, and perimenopausal women and contact lens users. So to summarize, preservative-free glaucoma therapy is probably a new standard in glaucoma care, been there for a long time, but we now have almost all companies that have come out with the preservative-free medication. Glaucoma is a lifelong journey. Holistic management extends beyond IOP control, especially caring for the ocular surface health. Many Indian pharma companies have launched the PF medication, and it should probably become an integral part of our glaucoma management. Thank you all for listening.
So, Dr. Moli, just one question. When you see a patient, you have diagnosed the glaucoma, and now you want to start treatment, your choice would be medication with preservative or without preservative when you're starting off on a naive patient?
I generally start with the PF medication, and I give the choice to the patient. Suppose the patient for some reason can't afford the more expensive PF medication, I also give the alternative of not using a preservative PF medication.
So a large part of this will depend on the kind of practice you are.
Absolutely.
So if let me ask Dr. Jyotsna, she heads a secondary center where most patients come from a rural background. Would preservative-free medicine be your first choice?
No, sir. They can't afford preservative-free because there are more expensive
The
medicines.
economics plays a very important role for across all patients. That's why I said you need to choose your patients.
So before all this actually came, in India, preservative-free medicine, the first one was, they were timolol-based eye drops. And they were truly without any preservative. They didn't do well. The company withdrew them because the shelf life was reduced. And doctors were not used to this concept there. And remember, an average Indian patient will put up with the redness and the itching and the irritation for a cheaper drug. And it's only a small select few that who would probably need. Though more and more people are becoming conscious, but cost still plays a role in the long-term management of disease. Tony, you want to add something?
Just one quick thing, that the one drug that we want preservative-free is timolol, and nobody will be able to do it because of price control.
Because of?
Price control.
Yeah, so preservative-free was very expensive. They came in unims manufactured by a company. I don't remember the name, but cost and I think the shelf life were issues.
If you run your own pharmacy, I think most of us would be prescribing lubricants by tons. So most of us, lubricants are very expensive, and most of them now are preservative-free. Very expensive lubricants. Most of them are anywhere between, say, 300 to 700 and so on. So pretty expensive medication, lubricants. With that in mind, I then explain to glaucoma patients that a preservative-free medication is far better in terms of the lubricant, plain lubricant, which you're probably using it without preservative anyway.
So compliance gets better because number of instillation times also gets reduced, and spacing and dilution of the glaucoma medication.
I think compliance adherence is the key element in glaucoma management, and we have seen that with various combinations as well. And even we are very skeptical about the triple combination that recently came in, whether it would really work at all, so many drugs into one bottle and so on. We did find that the drug actually works quite well, because the compliance immediately improves. With three medication, one bottle, your compliance is actually much better than 3 bottles or 2 bottles.
Preeti, you want to say something? Let's have it at the last thing, because
Press on the patient. I do agree that I love the triple combination, but when they miss one drop, they're missing
All of it.
So
All or
it
none.
has to be sort of drilled into them, don't miss.
so there's a 48-hour gap which happens in the window period. So I think on this note we will end. Thank you very much to the speakers and to all of you for being here. Thank you very much.